and above. Even we have started including the family medicine also, because that is also a part of the internal medicine. And now we have started the associate membership for the postgraduates who are in the first, second, and third year of their studies, their course. So they can also become member by paying half the membership fees. And then once they complete their this post graduation, they can pay rest of the fees and become the full-time members. And it is right now we started on 28th of March 2017. Only 10 people, and now the strength is 511 as the life members, 8 as the associate members, and we have 14 honorary members and advisors. And this Innovative Physicians Forum, the Medical Association, has been recognized by the Royal College of Physicians of Edinburgh, and RCPE, the president of RCPE is the ex officio member of our forum, and the Dean of Education and Training, Dr. Carrie Baker, is the full-time member, academic member of our forum. And they have paid the full fees to the forum. And then the first president, who was the ex officio member, Professor Andrew Elder, is now the honorary member. And for last 3 times, and this is 4th time that they are having their convocation for the new fellows here during our conference. The conference is planned on 29th and 30th of the August 2026 this year in Hotel Pullman, and it is a full 2-day conference in 3 halls and 2 workshop halls continuously. So that is the highest academic body. Dr. Sonal Saxena has also joined. We welcome you, madam.
Thank you, sir.
Good evening.
Now, because it is already 8:04 and 32 people have joined. So if the secretary of IPF Women's Wing, because this academic activity is under the banner of Innovative Physicians Forum Women's Wing. So I hand it over to the secretary, Dr. Princey Jain.
Thank you, sir, and good evening, everyone. Respected dignitaries, distinguished faculty members, esteemed colleagues, participants, and all dear friends, thank you for joining us today. It gives me an immense pleasure to welcome you all to today's CME webinar, Good Bugs, Bad Bugs, and Women Health, organized by IPF Women Wing in collaboration with Indian Association of Medical Microbiologists, Delhi chapter, under the aegis of Innovative Physicians Forum. Women health is increasingly being understood through the fascinating lens of the microbiome, from recurrent UTI and vaginitis to vaginal microbiome, the role of immunity, fertility, pregnancy, and overall well-being. This field has transformed our understanding in terms of prevention and patient care of various diseases. So today's webinar bring together 2 nationally acclaimed experts who have significantly contributed to microbiology and medicine. And I'm sure today's scientific deliberations will provide valuable evidence-based insights that can be directly used in the clinics. So on the behalf of IPF Women Wing, I extend a very warm welcome to all of you. It is my privilege to welcome our respected mentors and guiding forces. First and foremost, I extend my heartfelt welcome to Dr. Jugal Kishore Sharma, sir. He's a founder and Secretary General and Global Ambassador of Innovative Physicians Forum. And he's a fellow with distinction of Royal College of Physicians of Edinburgh and has been conferred the fellowships from all colleges of Royal Colleges of Physicians. Sir is international advisor to the Royal College of Physicians of Edinburgh for North and Central India. And he's an MRCP PACES examiner and medical director of Central Delhi Diabetes Obesity Center and scientific chairman of IPF Medicon 2026. Sir, thank you for your unwavering commitment to the academic excellence, continuous medical education. And we are truly honored to have your gracious presence today with us. I also welcome Dr. Sujadeep Sen Gupta sir. He's a president IPF. He's an eminent clinician and a very well-known internist, presently working at Saket in Delhi. Sir, we are thankful for sparing time and joining us today. I also extend my very warm welcome to Dr. Meena Chhabra ma'am, an eminent senior physician, diabetologist, and senior visiting consultant at SGRH New Delhi with over 3 decades of clinical experience in internal medicine and diabetes care. She's also a chairperson of IPF Women Wing. Ma'am, your leadership and encouragement are constant support that have played an instrumental role in strengthening this platform of women physicians. So I now request Dr. Jugal Kishore Sharma sir to kindly introduce our distinguished guests from Indian Association of Medical Microbiologists, Delhi chapter, Dr. Sonal ma'am and Dr. Jaswinder ma'am.
Thank you, Dr. Princey. I feel honored in welcoming Dr. Sonal Saxena. She is the Director Professor, Department of Microbiology at the prestigious Maulana Azad Medical College, New Delhi, and she is the President of Indian Association of Medical Microbiologists, Delhi chapter. We welcome, Madam, you here on this platform. Then I welcome Dr. Jaswinder Kaur Oberoi. She is the Chairperson, Institute of Clinical Microbiology and Immunology, Sir Gangaram Hospital, and she is the Secretary of the Indian Association of Medical Microbiologists, Delhi chapter. So welcome both of you, madam. And I would like you all to regularly have a collaboration with this forum for all academic activities. Dr. Princey, please.
Thank you very much, sir. May I now invite Dr. Sonal ma'am, President of IIMM Delhi chapter, and Dr. Jaswinder ma'am, Secretary IIMM Delhi chapter, to share a few words with the audiences.
Thank you, Dr. Princey. Thank you, Dr. Jugal Kishore, for the kind words. Now, as I welcome all the delegates here and everybody, this is a combined effort. IIMM Delhi chapter has been functioning as a very, very active chapter. In fact, one of the most active chapter of our national body, which is IIMM. And we thought that let's go out of our labs and have a collaborative CME where we can talk of many things like microbiome, antimicrobial resistance, infection prevention and control. And we talk with the physicians and clinicians and surgeons. So this is the first such effort, and the lead was taken by Dr. Shilpi and Dr. Jaswinder to collaborate with the IPF. And I'm sure all the students, delegates, everybody is going to have a great learning time. Dr. Rama is such a known figure on microbiome and such a learned person for all of us. Ma'am, it will be a pleasure to listen to you as always. So I think I hand over back to you, Princey. Thank you so much for having all of us.
Thank you, ma'am, for sparing the time despite your prior commitment. You spared us this time. Thanks a lot.
Thank you.
Jaswinder ma'am, few words from you.
Yeah, good evening, everyone. Dr. Sonal has expressed all my feelings, but I would just give for the benefit of all the from IPF also that IMM Delhi chapter. In fact, our national body is celebrating its golden jubilee year this year, so it is around 50 years old. And we, as IMM Delhi chapter, we have been functioning since 1993, so we are over 30 years old. So, and as Dr. Sonal said, we have been the most active chapter of our national body. And it's a pleasure to be associated with other societies. And I think we should carry this forward. And it will benefit all of us, including your as well as our societies. And Dr. Rama, obviously, it is always a pleasure to listen to you. And this is such an important topic, especially for the women's wing. And me being a woman, I would definitely love to hear it. And I think everybody would be interested in this. So thank you so much, Dr. Princey. Back to you.
Thank you, ma'am. Thank you. It's my proud privilege to introduce our first keynote speaker for the evening, Dr. Rama Chaudhary ma'am. She does not need any introduction, but still I would like to say a few lines. She's an ICMR emeritus scientist, former dean of research, and the former professor and head of the Department of Microbiology at AIIMS, Delhi. With an illustrious academic career of spanning over 4 decades, she has authored over 220 publications, including the international journals like the Nature and the Lancet. And she's a pioneer in India in the fields of mycoplasma research, anaerobic bacteriology, molecular diagnostics, antimicrobial resistance, and human microbiome. And ma'am's work has significantly shaped the infectious disease diagnostics and antimicrobial stewardship policies in India. And she has been an advisor to multiple national bodies like ICMR, DBT, DST, Ministry of Health, other than contributing to several WHO initiatives worldwide also. Bestowed with numerous honors and many other prestigious recognitions, ma'am would be talking on an important topic of the vaginal microbiome, the friend, foe, or the forgotten organ. So, ma'am, it's truly an honor to have you with us. Thank you for joining us. Over to you, ma'am.
Thank you and good evening to everyone. Can I have my slides, please?
Sure, ma'am.
It's really, I'm fortunate to be able to speak in this forum where I have I'm a Hardonian, you may not know. So good to know that hardly people are associated with it. So today I'm going to talk about vaginal microbiome and friend, foe, or forgotten organ. And this is something very close to my heart, especially the gut microbiome and studies on microbiome. Can I have the next slide, please? So just to keep the context.
Ma'am, slides are visible?
Yeah, they're visible. Can I have the next one?
Sure, ma'am.
So one should be aware that our body hosts large number of microbial cells or bacterial cells. In fact, they are even more than 10 times more than our human cells. And human body is home to these microbes, much more than human cells. So what is microbiome? This is assemblage of microbes, which can be archaea, bacteria, fungi, parasite, viruses, phages, especially their genes, which constitutes a microbial community and they occupy a specific habitat. We call it microbiota when we are talking about the bacteria per se, but here it is assemblage of genes when we say microbiome. And as the topic also said, and this was already there in my first slide, that it is a forgotten organ because, this is microbiome itself is an organ in our body which we never recognize, whether it is a gut microbiome, vaginal microbiome, or anything, because that is the one which is actually controlling a lot of immune responses and a lot of functions in our body. Next slide, please. So the history, if you go, in our time when we were student or residents, we did not know much about that till the Human Microbiome Project was started in United States. And then metagenomic of human intestinal tract, meta-hit program started in Europe. And then we started understanding that our body is full of microbes. Microbes are staying more in our body than our human cells. So what were the approaches which were used by people? In our time, we were using culture-dependent technique by isolating bacteria aerobically, anaerobically. But subsequently, large number of new organisms were discovered using culture-independent technologies, which are based on PCR or sequencing. Sequencing has become the major, player or approach. And then it shows there is so much of taxonomic diversity, there is so much of functional metagenomic, which we did not understand earlier, which we are slowly learning and exploring. Next, please. So how can we study this? So not only we come to know that what are the bacterial genes or bacteria present, because every bacteria has a signature, like we have our name as our signature. Similarly, bacteria also have a signature sequence which help us to identify these bacteria. And also it helps us to tell that what are the metabolic end products they are releasing. Therefore, we are able to understand the host physiology, how they are affecting immunity, development, and a lot of things. So how people have studied that, not only by nuclear magnetic resonance spectroscopy, but also other techniques. We have even people have used animal models like notobiotic animals, which is free of any infection, totally free of any infection. You give infection or a bacteria and see how it is behaving. And there is another model called zebrafish, which help us to understand a lot of mutations. Next slide, please. So, although this is not a microbiology forum, but it is important to understand that our body hosts, most importantly, 4 major phyla, which are called actinobacteria, bacteroidetes, firmicutes, and proteobacteria. It is the firmicutes which most of you will be familiar with, which also contains lactobacillus, which is a major player in vaginal microbiome. So if you see in this, it is showing in the body different types of microbiome. And if you see the vagina, it is rich in the red, which is the firmicutes, and the major constituents of firmicutes, the phyla, is lactobacillus. Next slide, please. So if you see how the female or a baby girl is evolving, you will find that there's a lot of changes which are occurring in vaginal microbiome. So, or in the vagina, the pH, which is high in the more towards alkaline side, lactobacilli are much less, and there is some diversity there. Estrogen is not there, but as reproductive age approaches, all these get reversed. So you will have low pH, you will have more of lactobacilli, you will have less of microdiversity in the sense that only one particular phyla, that is firmicutes, is rich in vaginal microbiome. And same happens during pregnancy, except few changes which occur at a minor level. And then at the old age, the picture is same as when you were born. That means estrogen levels has gone down, glycogen has gone down, vaginal pH is increasing, and your diversity with other organisms is going up, and lactobacillus is going down. So next slide, please. And there are, of course, large number of other bacteria. So when we see the role of vaginal microbiome, it is actually affecting a lot of diseases in human body. We talk about vulvovaginal candidiasis. We talk about bacterial vaginosis, which is caused by Gardnerella vaginalis, one of the very important bacteria. And I was fortunate, I think mine was the first thesis in India where we were able to isolate Gardnerella vaginalis, followed by my colleague, Dr. Aruna. She did it under Dr. Bhujwala. So both of us were there. And then you have a lot of aerobic bacteria which grow, like you have heard about E. coli, Klebsiella, and all those bacteria, and then anaerobic bacteria. So pH plays a role. And when the pH is altered because the lactobacilli somehow are going down, these bacteria will proliferate, and you will see the gram positive is going down, which is a lactobacillus feature, and other bacteria which can be spirochetes, which can be curved bacteria. Curved one is called mobiluncus, or Gardnerella vaginalis, and some of the anaerobes. They become rich in bacterial vaginosis. So, I mean, of course, names are not important, but what is important is to put it in such a way that good bugs are going down and bad bugs are going up in a simpler form. Next slide, please. So here you see the similar thing. So how the people have used this information now to alter the vaginal, microflora, which is, topic of great future concern, that how this, we call it dysbiosis. So once, and when it is healthy, we call it eubiotic. So when the dysbiotic vaginal microbiota is there, where patient gets a lot of discharge, itching, infection, and can lead to miscarriage in a pregnant female, preterm birth, infertility, PID, even cancer. So in such situations, one can think of modulating the vaginal microbiome by instilling something from outside, either in the diet or through vagina, which is called even vaginal microbial transplant, a new concept coming up after fecal microbial transplant. Next slide, please. So, though this is more of a microbiological slide, but what I want to show here is that it is the firmicutes, which contains the first bacteria here shown is lactobacillus, which is the richest organism in the vagina. But the research is showing that the other bacteria, especially coming into this group, which I will talk at the end of the end slides, is also becoming important. Next slide. So when we talk about this, bacteria, you will realize that there is a mammalian holobiont, we call it, that is microbiota host interaction. So, a lot of interconnections have started occurring during evolution, and bacteria became part of our body. And there was a symbiotic relationship. They were giving us vitamins, they were giving us protection from pathogens, they were strengthening our immunity, and they were balancing energy. So there was so much of functions which they were doing that we cannot be parted from these bacteria. In fact, in one of the tragedy, which is called Chernobyl tragedy, where radiation was exposed to some of the people, and all their healthy microbiota was killed, or the microbiome was killed. Those because of radiation, these people developed severe sepsis and could not survive, because you need this microbiota in your body to survive. So the two system, that is the bacterial system and host, they affect one another to orchestrate the whole organism physiology. This is how they balance and they play the different tunes in the form of healthy organisms, or what you call it, healthy body, and a lot of functions which I will talk later. Yeah, next slide, please. And so, in everybody, there is something called as core human microbiome. It doesn't change much, but there are many factors which affect the microbiome, and that is called variable microbiome, which could be because of the post immune response. There can be lifestyle changes. If you don't have good lifestyle, if you're not having good food, if you're having antibiotics, if you're having pressure, stress, anything, then your variable microbiome is majorly affected. The core more or less remains the same. This is what a nature study showed. Next slide. So I also want to tell you here, although we know that in vagina there is majority of bacteria are only lactobacillus, gram-positive bacteria, but it's also to understand that vaginal microbiome cannot work in isolation. It works hand in hand with gut microbiome. And in the gut, when a baby is born, there are not many organisms or not many diversity. Diversity means that 4 genera, which I showed you in the beginning, there are representation from all those genera. But as the baby keeps on growing, it acquires organisms from food, from environment, from even breast milk and things like that. And by the time baby is full grown, it has a rich diversity, and it is having good bugs in its intestine, which is going to help. And we have already seen that when the baby, reaches reproductive age, the vaginal microbiome will become rich in lactobacillus and the low pH. Next slide, please. So before it's also very important to understand, though we will not talk, I will not talk about in this particular lecture, but it's not just microbiome. That means not just bacteria. There is a microbiome, fungi, viruses, archaea, and a lot of other things, which determines not only gut microbiome but also the vaginal microbiome, because we all know about candida, vulvovaginitis, and a lot of fungal infections can occur. So that also one should keep in mind, though I'm showing the gut microbiome slide, but the concept remains the same. The other microbiome, or what you call other types of virome, phagiome, and things also exist. Next slide. So keep pressing. So when you get stress, so what happens? Before it affects vagina, the severe stress affects our intestine. So the beneficial bacteria, which is again firmicutes, which are lactobacillus, bifidobacterium, they go down. The pathogenic bacteria, like say for example, staphylococcus, E. coli, Klebsiella, Pseudomonas, which belongs to proteobacteria, they will go up. And you will find that total anaerobes are also going down. So the gut microflora and environment is significantly deteriorated in such patients. And this is what is going to also affect the vaginal microbiome. In fact, there are certain very good double-blind randomized trials which have shown that how both are interconnected. Next slide. So these are same as even in vaginal, that you get poor nutritional response will lead to dysbiosis of vaginal microbiome also. physiological dysfunction. Even with aging, we have already seen in old age or after menopause, your lactobacillus goes down, deficient immune response, you get more susceptible to infection and even can lead to cancer. So this is very important topic. Next slide. And there comes the role of probiotic. Now, because these organisms are what we call it as good bugs, are actually the probiotics which are present in our food, which are like in the form of prebiotic. And these bacteria, which are healthy bacteria, whether they are in the gut or in the vaginal epithelium, the concept I want to show here is that they are working by competing for the nutrients with the pathogens. So they will not let the pathogen enter into your vagina or intestine. They will not let, they will do bioconversion. They will have direct antagonism. I will show you some of our experiments which we have done. And then it will also affect the immune response. It will reduce the inflammation, which is a major role in bacterial vaginosis also. So this is how these bacteria, by competitive exclusion and very important barrier function of the epithelium. So the epithelium lining is very important, which becomes thinner in the in children and even in the old age. And that is where the barrier is lost, and that is where the pathobiont or pathogens are able to enter. Next slide, please. And at a immune level, it is very important to understand that there are two important cells in our blood, T cells, which are called T regulatory cells, and Th17 cells. And it is the balance between these interleukins, which are called pro-inflammatory cytokines or anti-inflammatory cytokines. We are looking for anti-inflammatory cytokines, which are coming from good bugs, and not the pro-inflammatory cytokines which are coming from bad bugs. So therefore, this balance becomes important to maintain in the intestine. Next slide. So when we come to maternal microbiome, it really, affects how it can affect the babies. So it is not just vaginal, that where predominantly lactobacillus is there, which is maintaining gastric pH, protecting against ascending infections, which are coming from the lower vaginal tract, and then gut, oral cavity, breast milk, everything is working together. It's not in isolation. In fact, body works more in unity. This microbiome also works in unitedly. And the physiological functions you are able to see, that is nutrient metabolism, vitamin synthesis, production of short chain fatty acids, which are very important for controlling the pathogen attachment to the intestine, immune regulation and maternal immune tolerance, maintenance of epithelial barrier integrity. This is very important, especially with STDs. If the vaginal epithelial barrier integrity is lost, then there are a lot of STDs one can acquire, including even human papillomavirus and cancers and things like that. So they are playing major role in controlling and becoming a guard. It's like that you are having a sentinel outside your house to control the entry of any foreign things. So this is where it is playing very, very important role. Next slide, please. So what changes it's going to happen? You will find that in the vagina, there is a when there are physiological changes are occurring during pregnancy, the lactobacillus dominates, and there is a stability. The vaginal pH will be low, and there will be a lot of this microbial diversity goes down. So there is a difference in vagina when the microbial diversity less means predominantly lactobacillus. It is good. But in gut, we do not call it good. We need more of different varieties of organisms. And so this is how physiological changes will, function together, whether it is oral microbiome, gut microbiome, vaginal microbiome. And this is how, it is going to modulate the birth of a baby, how it is going to affect the baby. Next slide. So they are playing, this maternal microbiome is playing fermentation of dietary fibers, to produce SCFA, which are called short chain fatty acids, which are metabolic end products, and they regulate the glucose and lipid metabolism. And they support vitamin synthesis and the nutrient utilization. It regulates the innate and adaptive immunity. It maintains the epithelial barrier integrity. It prevents the pathogen and maintains the homeostasis. So maintaining homeostasis means maintaining balance is very important in case of maternal microbiome to have a healthy, normal baby. Next slide, please. So if you see here, the dysbiosis during pregnancy, why it will occur, that if the patient has been given antibiotics because of some infection, we try to avoid antibiotics in pregnancy. If it is obese, not having good diet. So poor diet means lack of fiber. So you have to have good fibers to have a good bugs. If you don't have fibers in your diet, you will not have good bugs because they survive on these fibers, that oligosaccharides, diabetes and infection. So when you have these predisposing factors, you will lose the beneficial bacteria. That is again your good bugs. There will be reduced or altered diversity, and there will be increase of opportunistic pathogens which may be there in our body, not doing anything, but because lactobacillus has gone down or the guard has gone down, they will multiply. And there is an enhanced inflammatory response. Next slide, please. Next.
Doing it, there's some glitch, I guess.
Okay. No problem.
Just 1 second.
So because of all this, what is happening is that there can be birth of preterm babies. And because of the affecting, so this is what I wanted to show, preterm birth, where the dysbiosis has occurred. That means lactobacillus has gone down, Gardnerella has gone up. Some of the anaerobic bacteria, which are called Prevotula, some species, not all, they may have been affected. And there is a sending infection, there is inflammatory response, and baby will have, the female will have a preterm birth. We have done a lot of work on preterm birth and preterm, neonates, and then also pre-rupture of membranes, maternal obesity, pre-eclampsia. So everything, earlier we used to think microbiology is restricted to lab, only to do culture and report infection. But now the microbes are playing important role in all, even non-infectious disease, all metabolic disorders. So it is becoming so important to understand microbiome, which is actually shaping, the health of a person. So whether it is gestational diabetes, whether it is preeclampsia, pre-rupture of membrane, maternal obesity, preterm birth, everywhere this dysbiosis is going to play a role. And therefore, it is very important to understand that we have to maintain good vaginal microbiome. Next slide, please. Next.
Ma'am, I'm doing it.
Yeah, it's okay. So when we are talking about that, so there have been some studies even from India, from a center I saw in South, where they have tried to see the bacteria in healthy females and with the, kind of cancer of the reproductive tract. And they found that there are certain biomarkers, that means certain bacterial species, which goes up even when the patient has not led into invasive ovarian cancer or other invasive cancers. Presence of these bacteria in the vagina or in the gut can give you a clue that you should be careful and investigate that person properly, because this dysbiosis may lead to the to cancer. And these studies have shown, yeah, this is the one I was talking about. Thank you. So this is exploring the, you can go to that slide. So it is exploring the diversity of vaginal microbiota between healthy women and invasive cervical cancers. So it has shown the predominance of staph and the decrease in the lactobacillus gasseri in cases of cancer. But in healthy people, the lactobacillus gasseri or crispators, which are healthy normal microflora, they are there. So imagine just by doing the microbiome analysis of vagina, you can do the screening and prevent this kind of infection. Because ultimately, it will also help the HPV and other viruses also to lodge when the dysbiosis is there. Next slide, please. So we have done some work, not exactly in the vaginal microbiome, but how it is connected. I wanted to show you that. And we know unbalanced diet, stress, aging, antibiotic infection, I've already talked. And these are the conditions where it can lead to the infection or the dysbiosis. Next slide, please.
Yes.
The very first study we did when long back, I think in 2000, when we did not have any sequencing techniques available, and we were able to just show, bacterial species, a large number of bacterial species only by culture. We have used 6 or 7 types of media to tell that what are the aerobic bacteria, what are the anaerobic bacteria. And just to show you quickly, preterm babies and full-term babies have a lot of difference in their microbial flora by culture. I'm talking, this is the very first work we have done. And we found that the full-term babies had more of gram-positive bacteria, and they were able to have a better resistance to infection. Next slide, please.
Yes.
And then we did a study with the University of Maryland. This was an NIH project funded by, again, National Institute of Health Global Network project, where we did changes in gut microbiota after early administration of oral synbiotic. So synbiotic is when we are giving probiotic with prebiotic. That is the oligosaccharides along with the probiotic. And we found that a lot of new information came from this particular study. And we were able to show that how the changes in the bacterial population can affect the health of the young infants in that particular study. Next slide. So if you see here, there was a high level of bacterial diversity among infants which are examined in this study. Symbiotic treatment induced an increase in overall taxas. You can see the differences here. Gram-positive increased, especially in first week of life, and changes in the microbiota during early infancy should be used as a rationale whether we need to give probiotic or we do not need to give probiotic in babies. Next slide.
Yes.
So this is a very big randomized symbiotic trial we did to prevent sepsis among infants in rural India. This paper was published in Nature and it has more than 500 citations. So what we did here, we enrolled more than 4,000 babies in Odisha and 4,556 babies, which were, preterm babies, less than 2,000 gram of birth and 35 weeks of gestation. To half we gave the probiotic. We did not know. It was a double-blind randomized trial. So half of the baby received probiotic, other half received only placebo. And at the end of the study, we found that when the decoding was done, we found that those who received the probiotic, they had less infection, less death, less neonatal sepsis. And we chose Odisha that time as a site because Odisha has reported a lot of neonatal mortality and infant mortality. Next slide, please. So the editorial of the Nature mentioned about this paper that how probiotic could prevent infection in newborns. And if you see, this is the placebo group, which had higher number of deaths, sepsis, respiratory infection. This is the probiotic group, where there is lesser number of sepsis, neonatal infections, and even the respiratory infection. So this is what they have quoted here. The probiotic was given for almost 2 weeks, 2 to 4 weeks. Next slide. So then we did some lab studies to see whether lactobacilli, which we talk so much, they are in the vagina, do they really inhibit pathogenic bacteria? This was the thesis of one of my students. Next slide, please.
Yes.
We started with aim of C. difficile, but not only we did C. difficile, I'm not showing that data. I'm showing you data how these lactobacilli were killing directly. E. coli, Klebsiella, Pseudomonas, then S. aureus, Enterica, Salmonella, Enterica, and even Listeria. Listeria plays very important role in babies causing meningitis and early or late neonatal sepsis and things like that. And next slide, please. So
Yes.
we could identify 5 lactobacilli strains which were inhibiting all these bacteria which I have mentioned. So, and the antagonistic effect is either direct or because of H2O2 or because of bacteria. So this is how we were able to show that if we administer this particular lactobacillus strain, not all lactobacillus are good probiotic. You have to have identify the strain, characterize it. It should colonize in the gut, and only it is a good probiotic. Next slide. So we could identify 5 lactobacilli strain which were inhibiting all these bacteria which I have mentioned. So this is how we were able to show that if we administer this particular lactobacillus strain, not all lactobacillus are good probiotic. You have to have identify the strain, characterize it. It should colonize in the gut and only it is a good probiotic. Next slide.
Yes.
So this is another work we have done in different colon carcinoma, healthy Indian, and IBD. We can skip that. Next slide. And this is how it is showing in healthy and colon cancer what are the changes, and with the IBD, and how the firmicutes again, lactobacillus bifidobacterium are more in healthy, and there are others like megamonas, megasphaeria, Mitchquinella, rare species, because these we also heard the names first time. Because of sequencing we were able to get all these genera which we were not even familiar earlier. Next slide. Next. So this is the one I was talking about. Please go back. The randomized trial which has been done with Lactobacillus plantarum, which is called Probio 87, and it acts on gut vaginal microbiota. So we cannot talk about vaginal microbiota, vaginal microbiome in isolation. We have to take gut vaginal together. So what happened here? When they compared with placebo, the probiotic group showed a significant greater reduction in Nugent score. So we all know Nugent score is when you do microscopy, if you get more of lactobacilli, we label it as 0 to 3. And when we get more of other bacteria, which can be curved bacteria or anaerobes or others, vaginosis, Gardnerella, we call it 7 to 10 Nugent score. So it showed that the Nugent score was reduced in the probiotic group. It also showed improved vaginal health. The microbiota analysis showed that vaginal microbiota was able to suppress, using this particular probiotic, the BV associated taxa, that is bacterial vaginosis associated Gardnerella vaginalis or other taxas which are responsible for that. So these kind of trials are very important to understand how actually in clinical setting these bacteria are playing very, very important. Next slide. So there was in the title heading called friend or foe. So for all technicality, lactobacillus is a friend, but there is a lot of controversy that whether Privitola, which is another anaerobic bacteria, whether it is a friend or foe. So it has been found now that Privitola has large number of species, and every species may behave different. They do not, you cannot say in totality Privitola are pathogens or Privitola are healthy bacteria. So there is accumulating evidence which shows that members of Privitola family are not uniformly pathogenic. They play a very important role as symbiont and metabolic collaborator to context-dependent pathobiont. And members of these Privitola, especially these three, P. histolytica, melanogenicus, and corporis, are part of healthy vaginal microbiome. Next slide, please.
Ma'am,
I will,
yeah.
just two more slides. Yeah.
Sure.
So here it is showing a lot of diversity of Privitola. Next slide, please. And I just want to give you one example of one Privitola which causes vaginal dysbiosis. Or so, what are the future directions? Can I have the next slide? So, insight we are gaining from this study is we need to develop in clinical therapies for inflammatory diseases like bacterial vaginosis or candida vulvovaginitis or even cancer and things like that. Whether these principles are important in humans playing the immune system role, whether the range of commensal bacteria that modulate the maturation of immune system can be anticipated, and what are the dietary intervention. This is something can be easily done by us, because this we can control, dietary intervention. Next slide. And then just four other things that before we talk about vaginal transplant, we have to have better determinants to understand how this vaginal transplant or vaginal microbiome transplant, like fecal microbiome transplant, can really solve the problem or not. You just can't go and inject in everyone and everybody this vaginal flora taken from someone, and it requires a lot of studies. We also do not know what is global microbiota. There are hardly any studies, and there is a time series analysis are required, and we need to have a biomarkers. So with that, can I have the next slide? So I would like to conclude that probiotics are wonder agents, and not just probiotics. The healthy vaginal microbiome transplant can also work as wonder agent in future to promote healthy microbiome for good health as well as for prevention and treatment of various clinical conditions. And when it comes to good bug and bad bug, it is always a competition between them. It is up to us what we want. So when we control these factors, which I call lifestyle, health, not taking antibiotics, and good diet, I'm sure we can maintain that vaginal health. Next slide, please. So with that, I just would like to say that we edited this book on probiotic. Anyone interested may refer to this, and there are a lot of topics covered in that. So with this, I would like to thank IPF for inviting me and giving me this platform to share my views. Thank you so much.
Thank you, ma'am. Thank you so much for sharing your immense knowledge and experience and translating this research into the practical clinical insights. Thank you, ma'am, for this lecture and sparing time for us. Now, it's my pleasure to introduce our second eminent speaker, Dr. Anchan Kalia, ma'am. She has been my senior when I was doing my MD, and she's the inspiration because of whom I took medicine. So, ma'am is the professor and unit head in the Department of Medicine at Mahatma Gandhi Hospital, Jaipur. She's an accomplished physician, and apart from being an outstanding clinician and teacher, ma'am is also the MRCP PACES examiner, and she's the member of multiple national and state internist forums, such as she's the executive member of API Jaipur, secretary of Rajasthan chapter IRO, and scientific registrar of Rajasthan chapter of ISH, and executive member of American College of Physicians India chapter also. Ma'am has an academic interest in metabolic disorders, infectious diseases, women health, and medical education. And today, ma'am will be talking on the very important, common yet challenging clinical problem of day-to-day practice, tackling the recurrent UTIs and vaginitis in clinical practice. So, ma'am, the podium is yours. Please go ahead.
Thank you so much, Princey, and very good evening to all of you. I would like to thank Dr. J.K. Sharma sir for giving me this platform to speak on this very important topic. And I think speaking after Rama ma'am is itself a challenge, but she made my task easy because we got to know about the various microbiomes. It was difficult for me to read about it. It is really difficult. But thank you so much, ma'am, for making it simpler for me. Princey, I'll share my slides from here.
Sure, ma'am. Can I request everyone to please switch on the video on the screen? We would be clicking some pictures.
Okay, but can we remove this? Okay. Princey,
Visible
my
now.
slides are visible?
Yes, ma'am, they're visible.
Okay, so then I'll start. Give me a second. Okay. Okay. So, good evening, everyone, again. And today I'll be talking on the important topic, breaking the cycle, tackling recurrent UTIs and vaginitis. So when we talk about, so I will be restricting my topic and my talk to only the recurring UTIs which we face regularly. So I would not talk in detail about the UTI, but how do we tackle recurrent UTIs which we commonly face in our clinical practice. So what is the scope of the problem? And I think, Princey, you have rightly given this topic, because when I was reading about it, I was really amazed to see that, beyond 16 years of age, every woman, the annual prevalence of recurrent UTI is almost 11%. And the lifetime prevalence is 50 to 70%, and who will experience UTI. The recurrence rate again is 20 to 30%, and so much of money is being pumped into treating UTI, which we think is a very common problem, and we don't take it very seriously. But the amount of money which we are spending every year is enormous. So I think that's why this topic is really important for us. So when we define recurrent UTI by American urology definition, it says that more than 3 UTIs per year, or more than 2 episodes in 6 months, uncomplicated and or complicate episodes in non-pregnant women without anatomical abnormalities. So if you are having more than 3 per year or more than 2 in 6 months, it gets into the definition of recurrent UTI. What about American Association? They say that more than 2 UTIs within 6 months or more than 3 within 12 months. So the definition by European and American standard is almost the same. And the most common pathogen which is linked with recurrent UTIs is again E. coli, Proteus, Klebsiella, and Staph. And the route of infection, again, like ma'am described very well, that you have the intestinal microbiota, they colonize the introitus and the urethra and then ascend up the urinary tract. So this is how the UTI happens in females. So there are 4 subtypes of recurrent UTI. One is the unresolved bacteriuria, the persistent infection, relapse, and reinfection. There's subtle differences between all of these. So unresolved bacteriuria is that despite giving inadequate dose or duration, bacteria is never fully eliminated. So what is happening is that either the dose is inadequate, or maybe the duration in which we are giving the antibiotics, like we are not giving it for properly 7 days or maybe less than that. So the bacteria, they are never fully eliminated from the urinary tract, and this is the unresolved bacteria. Next is the persistent infection. So even after 48 hours of appropriate antibiotics, if we still have the symptoms of UTI, then it is known as persistent infection. And the most common causes, one is the calculi, the other is the resistant organisms. The other thing is that if you're not treating it properly or inadequate doses, or if we have some other problem like the anatomical problem, or the antibiotics which we are giving is not appropriate for the organism. So how is this treated? So cystoscopy and imaging is really recommended in these kinds of infection where you have a persistent infection. Relapse is that the same organism, it occurs after or recurs within 1 or 2 weeks of completing treatment, despite an initial good clinical response. So after 1 or 2 weeks, if we have the same organism, despite knowing that, we had a very good clinical response with the treatment in the first week, then it's a relapse. Reinfection is new species or same species after 2 weeks, or but during the interval there is a sterile intervening culture. So this is the most common subtype. So we have treated the patient, but after 2 weeks we have a new species or the same species, and in between we had a sterile culture. So this is what is called reinfection. So these are the 4 types of recurrent UTI which we clinically face. So what is the pathophysiology? A little bit of pathophysiology was touched by Rama ma'am. I would not be going into detail, but what is happening is that the healthy vaginal flora, it is dominated by lactobacillus species. There are multiple species, and they maintain a low pH and suppress the uropathogens. So during menstrual cycle or during illness, this shift in flora happens, and the uropathogenic E. coli, which is commonly found, and the Enterobacteriaceae, it colonizes the urethra. It is also most commonly seen in estrogen in the post-menopausal female, where the estrogen loss is there, and it thins out the urethra or the vaginal epithelia, and it depletes the good lactobacillus, which increases vaginal pH, favoring the uropathogen. So once the pathogens ascend up the urinary system, they form a biofilm, and that is how they ascend up the bladder, up to ureter, and they may cause pyelonephritis or complicated UTI. So what are the factors which are there, which we have identified, which can cause a recurrent UTI? So one of them is the sexual activity, most common one, which can be because of frequent intercourse, you have a new partner, or use of spermicide. So these are the independent risk factors which really have been seen in the randomized control trials, that they have there are independent risk factors for developing recurrent UTI. The other is the hormonal status. So like I said, the patients who are menopausal or have estrogen deficiency or have a vaginal atrophy. So these are the factors which can cause recurrent UTI. The other is the personal and family history. So if you have a prior history of UTI at early onset, or you have a maternal history. I was very surprised to see that if you have a maternal history of UTI, so again you are susceptible to having recurrent UTI. And then the antibiotic history. So if you have a recent antibiotic, it just disrupts the protective flora and uh, is the harbinger for the resistant organisms to grow. So when you have resistant organism or you have the protective flora which has been disrupted, there is this growth of organisms which causes recurrent UTI. So the next is how to assess these patients. So how to diagnose these patients. This is the most challenging part, because very commonly in our OPDs we see females who will come and say that that we are having dysuria. Abhi 10-15 din pehle we had, now again we are having, and there is minor vaginal irritation or no vaginal irritation, plus minus discharge. So these are the key symptoms with which the patient would present. The most common would be dysuria. They might or might not complain of fever, but yes, they might say that they have increase in frequency, urgency, sometimes hematuria, uh, urinary incontinence, and a typical presentation in elderly especially, they might present as encephalopathy. So septic encephalopathy, usually an elderly person presenting, we always think that this patient might be having a UTI. So you have to be very careful when you are assessing a patient, and you have to be very aware about the symptoms of UTI. So what are the urine culture thresholds? So in a symptomatic premenopausal, 10 to the power 5 colony forming units. If the patient is symptomatic, even 10 to the power 2, we consider it important. So how do we manage these patients? This was my topic, that how to prevent or maybe take care of recurrent UTIs which we are happening. And the foremost or the first thing is the lifestyle modification and behavioral therapies. Then comes your antibiotic treatment, the antibiotic prophylaxis, and further non-antibiotic prophylaxis, and the advent of some vaccines which are under trial, and some vaccines as in the market as well. So this is how we treat a patient of recurrent UTI. The first important is the lifestyle and behavioral modification. So if a person comes to you who has a history of recurrent UTI, you can ask the patient to increase the fluid intake to more than 1.5 liters per day. But you need to take care, especially in older patients, that they don't have a heart disease or something like that. So you have to, in permissible limits, you can say that to increase their fluid intake. There was this big randomized control trial done by Houghton and et al. And it was seen that in patients who are low volume drinkers, they have a 50% almost increased risk of recurrent UTI. So there is a low evidence and weak recommendation that fluid intake will help, but it does help. It is there in the trials. The other is the hygiene habits. Very important. We should all educate our patients on this, that when when you go to the washroom, please make sure that you are wiping from front to back. You should not douche, because you might then disrupt the flora of the perineum. Then, post intercourse, you should avoid, and just a little bit of cleaning is required. So all these hygiene habits, they have low evidence and low recommendation. They are recommended by us most of the time, because it's safe, it is a low cost, and it just increases your hygiene habits. But the evidence with all these is very low. But nonetheless, we should all educate our patients about hygiene habits, and maybe this would decrease the risk of recurrent UTI. The other is the contraception. So spermicide use is an independent risk factor. So if a patient feels that she has recurrent UTI, then we should switch the patient to a better option. And then again, if a patient is diabetic, make sure that the diabetes is under control, because as we all know, that hyperglycemia can predispose the patient to recurrent UTIs. So lifestyle and behavioral is the foremost thing, but again, the recommendation or the level of evidence is really low. Nonetheless, there is a weak recommendation for behavioral modification. So I would suggest that any patient who comes to us, we should always be talking about lifestyle and behavioral modification as the first line. Then is the acute antibiotic treatment. So all the guidelines, they say that the first line agents is nitrofurantoin. It has the lowest resistance risk. However, you should be very careful when you give nitrofurantoin, especially in elderly and in patients who have deranged RFTs. Trimethoprim sulfamethoxazole, given for at least 3 days. It has to be verified by a local antibiogram of the hospital. So it has to be given after collaborating with your antibiogram. The other antibiotic is the phosphomycin. It is easy to use because it's a single dose, and then it is convenient, and plus it is effective as well. The other first line agents which we commonly use are the fluoroquinolones. However, there is a little catch to it that they might cause QT prolongation, and they disrupt the fecal microbiota. The other antibiotics which can be used is amoxicillin clavudic, the commonly called augmentin. So it is inferior to vaginal E. coli eradication, but it is used sometimes if the culture reports are there. But it was seen in the randomized control trials that the higher reinfection rates were seen in patients who were given amoxicillin acid as compared to other drugs. Excuse me. Then comes the antibiotic prophylaxis. So we have three phases to antibiotic prophylaxis. One is to give in a continuous manner. The other is the post-coital. So when we talk about continuous prophylaxis, so it was seen there are multiple randomized controlled trials over it. It was seen that if you give a patient a continuous prophylaxis for at least 6 to 12 months, but you have to reassess every 6 months, and there was no single agent which was proven superior. So you can give nitrofurantoin, you can give trimethoprim sulfamethoxazole, you can give cephalexin or phosphomycin 3 gram every 10 days. So these are the antibiotic prophylaxis which has to be given in a continuous manner. So it was seen that when you have and when you give antibiotic prophylaxis in a continuous manner for maybe 6 months to 12 for a year, the recurrence rate was less as compared to patients who did not use a continuous prophylaxis. Then is the postcoital. So this is also important. It was seen that a single dose after intercourse is as effective as daily prophylaxis for sexually associated recurrent UTIs, right? So either you give a single dose, it was almost equivalent to giving a long-term antibiotic prophylaxis. So again, the doses or the drugs would be the same: trimethoprim sulfamethoxazole, nitrofurantoin, cephalexin, or ciprofloxacin. But again, the quinolones have a higher toxicity rate. So the other drugs are most commonly used even for postcoital antibiotic prophylaxis given in patients of recurrent UTI. Also, when you have these patients, you should always screen them for chlamydia and trichomonas, because in sexually active women, the cause of recurrent UTI could again be these atypical organisms. Then this is very important and interesting. So when I was reading about it, so one was the behavioral changes, the other was the antibiotic prophylaxis which we preferred, and then these non-antibiotic approaches which I came across. So one is, so these are the this thing probiotics. Again, ma'am touched a little bit about them. So cranberry, vaginal estrogen, methenamine, D-mannose, probiotics, vaccine, and hyaluronic acid. So there is weak to insufficient evidence against most of them, but yes, they are there. There are multiple trials around them, and let's see one by one how they affect. So why the non-antibiotic approaches came into view? Because it was seen as a last resort after giving so much of prophylaxis, that maybe something else is there which might help in preventing recurrent uh, UTI. So when I'll briefly touch one by one, one is the cranberry products. So cranberry has proethanosinidins, and it blocks the adhesions of the fumarate uropathogens to the uroepithelium. So it is basically an anti-adhesion, but not a bactericidal. So there are almost 50 studies on it. The evidence is weak, and the recommendation is also weak. And level, it is not a very well accepted this thing, but it was seen that if you dose 18.5 milligram of PAC per day, it reduces risk in women with less than 5 UTIs per year. So it was seen that maybe giving a cranberry product would help in reducing the recurrent UTIs. There are almost 50 studies and around 10,000 participants which have been studied. So it definitely reduced the symptom and culture verified UTIs in women with recurrent UTI. So there is some evidence about it. The other is the methenamine hippurate. It was initially used when before the antibiotic era. The evidence is very low about it. It is not easily found nowadays, and I think nobody of us is giving methenamine hippurate for recurrent UTIs as if for now. Then is the vaginal estrogen. So in postmenopausal female, there is a strong evidence about vaginal estrogen. So what is happening is in patients who receive estradiol ring, it was seen that the UTI experienced was at least 91%, the rate of reduction was at least 38% more in patients who were using vaginal estrogen, especially in females who were post menopausal. Oral estrogen had no benefit, but yes, vaginally, if you're using 0.5 milligram estriol 2 to 3 times per week, the level of indication is very strong, especially like I said, in postmenopausal female, and it is level 1B. So it reduces the relative risk by 0.42. And I think around 51.9% reduction in UTI was seen in patients over a year of follow-up in this particular study, which was done on around 5,600 patients, and there was a very high reduction in the UTI. So I think the strongest evidence in the non-antibiotic approaches is about vaginal estrogen. Why is it underused? That I have also never used it. So why is it underused? One, because it does not have a proper FDA approval for this specific indication for preventing UTI. Again, the estrogen safety concerns, they persist among patients and the caregivers as well. However, the evidence is robust, and we must be, doing more research about using vaginal estrogen for preventing recurrent UTI. Then is the D-mannose. Basically, the mechanism is it blocks the E. coli type 1 pili adhesion to the uroepithelial cells. It is well absorbed. It is renally excreted with minimal side effects. So how is it given? It is given 2 grams per day for at least 6 months. And in one particular study, it was seen that it reduces the rate of recurrent UTI by around 15 to 20%. What does the guideline say? It has a weak to moderate recommendation by the European Association of Urology, but the cost is very high. So the cost versus uh, the cost versus benefit ratio is still a problem. So I think there needs to be more analysis about it. However, we are not using it currently. So D-mannose again is promising, but it is inconclusive. Then comes the probiotics. So this is one important topic, and I think Dr. Rama would also agree with me. Like ma'am said that the microbiome is so important. So what was the rationale that the Lactobacillus crispatus, which is more commonly there in the perineum, it adheres to the uroepithelium and blocks the uropathogen attachment, restoring the vaginal microbiota. So there are a number of studies on it, and this suppository was introduced, which reduced the UTI to 15 to 20%. There are oral forms of probiotics also available, but they are not as effective as the vaginal suppositories. So there are multiple systemic reviews which say that vaginal lactobacillus may benefit, but again the evidence quality is too low, so the EAU has not recommended till now, and the level of indication is weak. Then is the hyaluronic acid and chondroitin sulfate combination. Again, this was used. Intravesical hyaluronic acid was put in patients who had recurrent UTI. But again, the level of indication is extremely weak, and it has been reserved for patients who have failed even the invasive options like cystoscopy. And then when very important is the acupuncture, Chinese herbs and vitamin supplements. So acupuncture does not relieve the UTI, but again, they may reduce the symptoms of cystitis. Vitamin C, the role is again plus minus. There is insufficient data. What does vitamin C do? It just acidifies the urine, and you have a bacteriostatic environment, which does not make the microbiomes to grow. So, sorry, the microorganisms. So, this might help. Then is the Chinese herbs. So, the Chinese herbal medicine plus antibiotics. There was this study which said that if combined together with antibiotics, the Chinese herbal medicine outperformed antibiotics alone. But most of the trials were done in China, so they might be biased with their study. And then is the vitamin D. The level of indication is very low, but the confirmatory studies need to be there. So with vitamin D, the evidence is really low. Then comes the surgical part. So if you have recurrent UTI not getting corrected with antibiotic prophylaxis or maybe a long-term antibiotic course, then these are the surgical techniques which are available, like endoscopic fulguration of inflammatory lesions at the urethra, bladder, neck, and trigon. Then is the important topic of vaccine. So like ma'am said, that we see shift from this microbiome, and they might be used in the vaccines which are available to reduce the episodes of UTI. So one is the Eurovaxom. It is the meta-analysis have been done. We are still waiting the results. It is available in Europe and not in US. So it just boosts the Ig and IgG, both humoral and cellular immunity against E. coli. So the recurrence of UTI is less. Then is the M140 and other, these are the other emerging vaccines which are there, the MB140, FIMH vaccine. Because of the lack of time, I'll not discuss these in details, but these are the emerging vaccines on the block which might help to reduce the recurrent UTI. So just to end my talk, the strong evidence is in favor of the antibiotic prophylaxis and antibiotic treatment. There's a moderate evidence with D-mannose, hyaluronic acid, and probiotics, and insufficient evidence with acupuncture, vitamin C, and vitamin D. Nevertheless, we should always be very careful about what we are treating. So, UTI, I think, is one of the most favored uh, uh, infections where people would give antibiotics. The patient knows what antibiotics to take, so they take over the counter medication. So this resistance landscape with both quinolone and cephalosporins is spreading very fast. So we need to be very cautious about how we treat these patients. When we when we put these patients on prophylaxis, then we should make sure that every 6 months we should review these patients and discontinue if UTI is not there. So how this is the practical algorithm for every clinic. You see the patient, you take a proper history examination, you do the behavioral counseling, non-antibiotic prophylaxis if required should be there, and low dose antibiotics if required over long term can be given as antibiotic prophylaxis for these patients, which should be regularly monitored after every 3 and 6 months to de-escalate, escalate, or stop the antibiotics. That is very important. So one slide about the postmenopausal women. So in these patients, the pathophysiology, again, like we discussed, is the estrogen deficiency, which causes vaginal atrophy and loss of lactobacilli. The pH is elevated and the uropathogen colonize. So this is the treatable cause. We can give estriol in these patients to decrease the chances of recurrent UTI. Additional options in these patients could be, cranberry, and this vaccine is come up in a big way. Eurovaxom, European Union strongly recommends it, but it is not available in US as of for now. So special population, you need to take care about the elderly patients, pregnant women, especially neurogenic bladder, and patients with CKD. So In patients who have CKD, like I said, we should avoid nitrofurantoin, but these are the special populations needed to be taken care of in patients with recurrent UTI. These clinical takeaways should, one is that the culture should be a mandatory before treating antibiotics, especially in patients who present with a recurrent UTI episode. First, start with lifestyle, like I said, fluid intake, behavioral hygiene. Treat the underlying cause, especially in postmenopausal female. We can use vaginal estrogen, antibiotics if may needed for a long time. So reserve prophylaxis for non-antibiotic failure. Reassess, like I said, every 6 months and choose by the local antibiogram, and watch out for the vaccines which are up at the horizon. So vaccine is also important in these patients. However, the data of long term is awaited. Thank you so much for your patient listening. So an ounce of prevention is worth a pound of cure. So I think prevention is more important than treatment. So this is important for all of us.
Yeah. So thank you, Anchin ma'am, for such an engaging and a detailed presentation. And I think your lecture has beautifully combined the evidence-based medicine with the clinical points that can be used in the clinical practice. So as we move to the discussion session, we'll keep it very short because we have already crossed till 9 p.m. So I think
I have a question. Good evening, Dr. Princey, Dr.
Good
Meena
evening,
Chabra.
ma'am.
Hello, ma'am.
Hi, Anjan. Very good talk. Thank you so much. It was wonderful listening to you. I have a question. We see reports with leukocyte esterase positive in urine routine, but no pus cells. Does that report warrant a culture sensitivity in the patient?
So, ma'am, when I was reading about it, so when you have leukocyte esterase, and the patient is symptomatic, you really need to do a culture. However, if the patient is asymptomatic and and has no risk factors, so this can be just with the lifestyle and behavioral therapy. This can be treated well. However, if the patient has symptoms, he's a diabetic, he's immunocompromised, then this report needs to be treated and a culture needs to be sent.
Right. So,
Ma'am, in
don't.
pregnant. Sorry, ma'am, please carry on.
Yeah. What about renal transplant? So they also come in the same category as pregnant women.
Yes.
So if a UTI has to be treated very aggressively in a patient of renal transplant.
Oh, yes, ma'am. I'm in the transplant committee, and believe me, these patients are so immunocompromised that any infection which come up, especially, and these patients have very different bacteria from which we see in normal
Yeah.
patients. So at the onset only, if the patient has fever, cultures need to be drawn, blood cultures, urine cultures, and then needs to be treated. I am not sure whether the renal transplant patients are more prone for UTI. I think they are generally prone to infections. I'll really have to go back and read whether these patients are more prone to UTI, or any infection is of the same value in them.
And one more question, that when you give sulfur drugs, suppose the patient says, I don't know if I have allergy, do we still go ahead and give? Because that's one very important drug we have in our armamentarium. We use a lot of sulfamethoxazole and trimethoprim. Do you also use, Dr. Princey, what about you? For long-term
Ma'am,
prophylaxis?
if the patient is allergic, then I think we'll take the other alternatives, phosphomycin.
No, not allergic. He doesn't know.
He
If
doesn't
he's
know.
allergic, obviously he will get a Steven Johnson. No. If we don't know, because these days people have grown up without taking,
Ma'am, if you
Exactly.
ask me in my clinics, I would take caution. I would rather try other classes first. If not responding, then I'll switch to that.
because
Meena, ma'am,
because these are Dr. J.K. Sharma is here. Sir, are you
Yes.
there?
ma'am, this is a
Yes,
very
yes,
important
I'm very much
observation.
here.
So,
Meena,
sir,
ma'am,
we
this is a
should
very
give.
important observation. So
Mm.
what is happening is I am now seeing that, since last 20 years, most of us have stopped using trimethoprim because of other drugs which are available. So now the culture which comes shows that this patient, they would be resistant to so many drugs, but they are resistant
Yeah.
to trimethoprim.
Yes,
Very
that's what I'm telling
surprising.
Princey, that Dr. Princey, they
Yes,
respond
ma'am.
beautifully chronic
Yeah.
UTIs and
They
recurrent
do, ma'am, because
UTIs.
what I have also seen, right? Your ma'am is rightly said that I think the resistance has gone down to these drugs, and they respond really
Yeah.
nice to them. If
Like
we take the
Entric, we are
over,
seeing so much
it's better than
resistance. It's
the newer
Mm.
drugs.
Yes,
Madam, I
absolutely.
would
So,
like to ask a question. Can I?
Sure.
I would like to ask I am Dr. Thomas Status, cardiologist from Trivandrum.
yeah, sir, good
I think
evening. A very warm welcome.
Hello. Yeah, thank you, madam. See, I'm a clinician. I would like to know what about now that the SGLT2 inhibitors are so rampantly used and very effective and cardiac friendly.
Yeah.
What is the incidence of infections, and what are the organisms which produce vaginitis and urinary tract infection with the use of the SGLT2 inhibitors?
So
Again, I
can
think,
I?
sir,
Yeah.
ma'am,
Sorry,
I
Anshin,
think,
go ahead.
no, ma'am, please go ahead.
No. He was. So yes, sir. We were saying that we have published a paper just now on the incidence of UTI and genital tract infections. So genital tract infections there's a very interesting pattern that we noted. In the inpatients, usually vaginal infections are bacterial, but what we see usually they're fungal. What we see in outpatients usually. So as far as genital infections are concerned, in women and in men, we do see balanitis, balanoposthitis with SGLT2 inhibitors. You withhold the drug, and my take is that if you restart SGLT2 inhibitors if there is a compelling indication, like in your practice, if the patient has heart failure and you want to give it, and but if he develops a second episode of a male balanitis, balanoposthitis, or a female develops urinary tract infection or vaginal candidiasis or bacteria, then you should stop and not give it. So second time we can reintroduce, we can actually, reinforce genital hygiene, particularly uncircumcised men, because I'm yet to see genital infection in circumcised men. It doesn't happen. But in uncircumcised men, we have to reinforce genital hygiene. And in women, both, we have to take care of genital infections and urinary tract infections. So UTI is not that common. Dr. Sharma is here. We see a lot of genital infections. In my practice, I see at least 10 to 15% of my patients develop genital infections, and it's usually fungal.
So,
It's
Dr. Meena,
candida.
Dr. Meena and Dr. Anchin,
When do you restart, madam? You said you should give a gap and then restart.
Yeah.
Is it after 2 weeks
So,
or?
yeah, Dr. Manchanda, I'll answer. Go ahead. You were asking
No,
something.
I was just asking first one thing, to
Hmm.
whom you should label the infection only a simple pyuria? Does it mean any indication that we should discontinue the medicine? In my practice, I don't unless patient is symptomatic and shows some cultural signs, cultural levels of any infection. So patient may come up with certain pyuria. It is 10 to 20 pus cells, but patient asymptomatic. There is no.
Yeah, that Dr. Anshin was very clear about it. Asymptomatic pyuria, don't treat. Get a culture done. Only if you culture something, you should go ahead and treat. So I think that is clear. You are very correct,
Yes,
sir.
yes.
Now, so sir has a question. When do you restart? So I think all of us can answer that.
Dr. J.K.
Since
Sharma will answer this question.
No, Dr. Sharma is perhaps arranging another meeting.
Sir,
Busy
no.
man.
Very important is that, very rightly said, but we are mixing two things: urinary tract infection and the genital infections. The genital infections are common with these SGLT2 inhibitors, but if the genital local hygiene, personal hygiene is not maintained, and it has been seen that if the personal hygiene is maintained, the area is kept dry, and in that case, the genital infections are very, very less.
No,
And
sir,
hardly,
no. No, Dr. Sharma, I beg to disagree. There is something else. Some of my upper class women who claim to have good genital, hygiene also develop. And I think I reinforce, perhaps because we are all female physicians, they come back to us once you give SGLT2 inhibitors and they develop infection. So incidence of genital tract infection in a moist environment like India, perhaps Delhi, is about 10 to 12%. Even by reinforcing genital hygiene, I do see 10% of my patients develop genital infection. Urinary tract infection is rare, unless the patient has an overactive bladder, has residual urine, then we should not give. But doctor, our cardiologist friend is asking, if there is a compelling evidence to give SGLT2 inhibitor, what will you do? I think I will restart after 2 weeks. What about you, sir? We will stop the SGLT2 inhibitor. We
I
will
think that is
treat,
a recommendation, madam.
yeah,
Yes,
2
That is
weeks.
exactly the recommendation. But then you have to watch for if the patient gets a recurrence. You are absolutely correct.
But it has
one
also
thing,
been seen that if we start the SGLT2 inhibitors with the DPP4 inhibitors,
Yes,
the
yes.
infection rate
Maybe.
goes down.
Yes.
now
That
as
is
a,
also there. So if there is an
Yes, yes, correct.
can
there
I
is
say
an
something?
yes, ma'am.
As a microbiologist, I'm seeing a lot of, as Madam said, a lot of vaginitis, like a Candida vaginitis, and definitely there have been a lot of resistant organisms there also. So if there is a fluconazole resistant organism, say even in Candida albicans, we are seeing fluconazole resistance. Then how do you treat it, Dr. Anchin? If you can answer the question.
Ma'am, so if we have recurrent vaginal candidiasis, did you say?
Yeah, yeah.
So
With the resistant organism.
so
Fluconazole resistance, because fluconazole is given is the drug of
exactly.
choice otherwise.
Yeah,
These
yeah.
are the patients who are generally diabetic patients. So one, the culture is important, but the problem is that the culture takes a lot of time. So in these patients, if we feel that the patient is immunocompromised, we switch over to the other antifungals like voriconazole.
Itraconazole.
Ma'am, itraconazole not, but
Same.
maybe if the patient, but maybe voriconazole and then echinocandins.
Yeah.
Yeah. Have you
Dr.
ever tried
Kali, I
boric
want to
acid or
ask you a
nystatin?
question. Yeah.
No,
Because
nystatin.
that is a recommendation by DSA.
Yeah, nystatin.
Nystatin and even boric acid. People are trying for in our hospital. People are trying and they are getting good results.
This
With?
is something which is new to us. Boric acid they are using. Nystatin, yes, we have used, but not boric
You
acid.
can go to the IDSA,
Dr.
vulvovaginitis candida.
Okay.
Yes.
Dr. Kali, I want to ask you one question. You are mentioning that ciprofloxacin causes tendinitis and aortic rupture. How does that happen?
I don't know. It was there in the guidelines. I went through it. There was anecdotal reports which say that ciprofloxacin maybe in children because of the ligament.
Yeah.
Yeah, so it was there mostly in children where you have it
It's a
hampers the
warning with
ligament growth.
fluoroquinolones.
Yeah, so
Yeah,
it's not
Because we have
recommended
never
for children.
we have never seen this complication.
I have
But
also
sir,
never
it is
seen it, but
clearly
Surprisingly.
if it's
mentioned.
mentioned, you
Yeah.
have to write it. It was
No,
there
the
in
pediatricians
Yeah.
never give it
exactly.
because,
That's
and
why
also an
pediatricians don't give it.
increase, they might cause an epileptic seizure in some patients who are prone to
Definitely.
seizures. But the most common thing we see, Dr. Anchin will agree, Dr. Princey will, is hypoglycemia with these drugs. So if you're
Diabetes,
giving
yes,
them in a
yes,
patient of type 2 diabetes on
you have to be careful.
sulfonylurea, you have to be very careful. Tell the patient to monitor because all of them can cause ciprofloxacin, ufloxacin. The patient comes with
Especially
hypoglycemia.
elderly patients, ma'am.
Yes, yes,
I
Dr.
usually
Princey.
avoid giving
So,
Quinoline in
No, I think
Yeah.
that was with actually gatifloxacin,
No,
which is
no,
now
with all,
given up.
sir. I've seen
Which is
with
now
all.
given up actually.
No,
even levoflox also, sir.
you can get hypoglycemia.
so one thing
Absolutely.
I just want to make that we take the help of, in case of resistance for the bacterial or the fungal
Mm-hmm.
medications, we take the help of our microbiologist. In
Yes.
Gangaram, we have the special arrangement that the microbiologist or microbiology department, they suggest us which antibiotic or which antifungal should
Yes,
be
yes,
used
yes.
in this case, which will be effective. I think Dr. Jaswinder will agree with me.
No, I think
I'm
they
very
also
fortunate that our
I,
clinicians listen to us also.
no, I think
We also
microbiologists
do.
also give a numerical number. The microbiologists give a numerical number
Yeah,
to
yes, yes.
say the order of preference of a drug.
Yes, yes,
I wanted to
yes.
ask Dr. Chowdhury one question. What is this ARCA organism? I've never heard of it.
Organism?
ARCA organ,
Yeah,
ARCH.
archaea.
I've never heard of
It
it.
is a yes. Archaea is a genera. So we have in the plant kingdom we have four major phyla which I showed in the first slide. So archaea is one of those, and these are also organisms which causes more of animal infections. Not so much in humans we have seen it, but yes, it is one of the phylum of the plant. Microbes you can.
Okay.
Yeah, you showed in the slide. Thank you.
Yes.
Okay, so I think it was a good discussion. Any comments from our guest faculty, Dr. Shilpi Khanna and Dr. Shweta Dahiya?
Hi, Dr. Princey. Thank you.
Hello, ma'am.
Both the speakers, Dr. Rama ma'am and Dr. Anchin, both have spoken up almost everything. And Dr. Rama actually highlighted everything about the microbiome. And Dr. Anchan very beautifully, she narrated the entire AUA guidelines, which is actually required for management of recurrent UTIs. And the discussion was really meaningful. I think if Dr. Shweta has anything to say about, I'd pass it on to her.
No, ma'am, I think most of the important questions have already been answered by the very beautiful guest, very beautiful lectures. And I think almost everything has been covered that can be covered in this topic.
You were right. Very beautiful speakers. You
Yes.
were saying that, not just the top speakers. Yeah.
Dr. Jayashree Swan, she is a senior professor at Cuttack or Bhubaneswar.
Yes.
So can we have a comment from Dr. Jayashree Swan? She is the executive committee member of this IPF Women's Wing also. Dr. Jayashree, your views, please. Are you not there?
She's logged off, sir.
I
I
think.
think.
So I think we move on to our conclusion part for today's scientific session, and it's my privilege to invite Dr. Surjadeep Sen Gupta sir, President of Innovative Physician Forum, to deliver the concluding remarks. So kindly
So,
address the
yeah,
gathering, please.
so good evening, everyone, and thank you, Dr. Princey, for organizing such a fabulous webinar, in conjunction with the IAMMDC. It was actually a treat to listen to both these very fantastic deliberations, and it was very gratifying to see almost more than 55 odd persons who had logged it at one point in time. Both the topics were very novel and important, and not usually discussed in the routine medical seminars, as we know. So it was indeed a privilege to hear both the talks and gain a lot of knowledge about it. I personally found these things about the vaginal microbiome transplant, the link between the Chernobyl disaster, as ma'am said, and the microbiota destruction, and the link of stress with microbiota. They were very fascinating concepts and things which have, we need to really discuss in the future also. And also the anti-inflammatory, pro-inflammatory effects of the bugs which go on to make the entire microbiome in the body. And also the second lecture about recurrent UTA itself was again a very relevant topic, and a lot of knowledge we gained. I think all of us gained immensely. It was also interesting to know about the Chinese herb therapy. I mean, I'm not a very big fan of these Chinese herb things.
Me also.
But the one thing which I noted in that particular slide was the 7 randomized controlled trials, which had only 542 participants. So whatever. So I would take it at face value, but obviously there's something. I don't know whether Chinese herbs are available for us out here for treatment, or whether we do anything about it.
So there,
And
in fact, I met one of the foreign faculty in one of the conferences, and he was carrying all these herbs with him.
no,
I'm not sure for many other reasons, but they must be having these. So we
must
also
be.
have so many Ayurvedic
Yeah,
preparations
yeah.
for
And
treating.
and the
Yeah.
concept of vaccinations for recurrent UTI and vaginitis were extremely interesting. Do we have any vaccinations available for the general public right now? I'm not aware of.
So I'm also not in India, so that is
Yeah,
only available in European countries, not even in US. So
yeah.
India, so it's not there.
Yeah, right. So all in all, it was a very fantastic CME webinar, and thank you both the speakers for putting in such a huge amount of effort, and we all gained so much. And my thanks to both the speakers. I would just make a personal request: if both the slide decks are available to all the participants of IPF, is that possible, Dr. Princey? Because you would like
Uh,
to go through them at leisure, and read through, and the
This entire
fantastic bits of
presentation is
knowledge.
available on YouTube.
Okay, okay. No, but if the slide decks are available as PPT presentations, which, if it's possible, I was just making a request. And lastly, Nari Shakti, we all know, is important for all of us. And I would take this bit of time to just ask for your votes for Dr. J.K. Sharma, sir, who's standing up for the president-elect in the RSSDI election. So I hope all of you would en bloc vote for him and make him successful. And thank you very much, one and all, for participating in this very wonderful webinar. Good night to all of you.
And
Thank you.
one more
Thank you.
announcement that the Innovative Physician Forum IPF Medicon 2026, the scientific program is nearly final and it will be declared in 2 to 3 days time. And everyone, all IPF members and others who are a part of the scientific this deliberations, they will see their involvement. Dr. Puneet Khanna is going to finally hand it over to all. So thank you everyone, and madam, thank you.
So,
Special thanks
thank
to Dr.
you.
Rama and Dr. Jaswinder and all the speakers. Dr. Anchin Kalia is our own speaker, so I don't propose a vote of thanks to her.
I would
Absolutely.
also like to thank
Thank
May I
you
now
so much.
request
Thank you so much.
Padmashri ma'am
Thank
to
you.
propose the vote of thanks?
Thank you so much.
Good evening, everyone. I think Dr. Sengupta and Dr. Sharma have really done my job, but it's my privilege to propose a vote of thanks formally. So I would like to express our deepest gratitude to esteemed speakers for sharing their knowledge and clinical wisdom this evening. Dr. Rama Chaudhary, who spoke so well on the vaginal micro, friend for forgotten organ, and microbiome, indeed, it's an organ. And this talk truly encouraged us to look at this often overlooked ecosystem with fresh clinical lens. Dr. Kalia spoke very well, and we thank her for her practical and insightful talk on breaking the cycle, tackling recurrent UTIs and vaginitis and clinical practice, with important takeaways for our everyday practice. Sincere thanks also to our guest faculties, Dr. Shilpi Khanna and Dr. Shweta Daya, for enriching today's discussion with their perspective and expertise. I would like to especially acknowledge Dr. Princey Jain, our moderator, for steering the session so seamlessly and ensuring flow of discussion throughout the evening. This webinar wouldn't have been possible without the guidance and support of our senior leadership. I extend my heartfelt thanks to Dr. Jugal Kishore Sharma, Secretary General and Global Ambassador of IPF and a candidate for RSSDI Presidentship, Dr. Surajdeep Singh Gupta, who is the President IPF, Dr. Sonal Saxena, who is President IAMMDC, and Dr. Jaswinder Kaur, Secretary IAMMDC, for their continued encouragement and support to this collaborative initiative. I would also like to thank the entire IPF Women's Wing team, including the chair, Dr. Meena Chawda, who so actively engaged in the discussions, and the executive team for their tireless efforts and behind the scenes contributions that made this event possible. Finally, thank you all, the delegates and the participants who joined us this evening on Zoom and YouTube. Your active participation and engagement are what truly give meaning to these academic endeavors. Thank you all once again.
One more information for all, that Dr. Princey Jain, Professor of Medicine at Lady Harding, she is the subcommittee member who decides which are the feeder subjects for the DM in various categories, DM Endo, DM Cardio. So she is one of the 3 committee members to decide which feeder post-graduation should be taken for which and DM courses.
Oh, wow.
Congratulations, Dr. Princey.
Congratulations.
This is from NMC, National Medical Commission.
Oh, wow,
That's
fantastic.
nice.
Thank you.
That's so nice.
Thank you.
So
Fantastic.
good recognition to Dr. Princey, and indirectly a good recognition to Innovative Physician Forum Women Wing, and then to Innovative Physicians Forum. Thank you, Dr. Princey.
So like to thank IIM, Dr. Sonal and Dr. Jaswinder, and she really has been following up for a long time, and Dr. Princey for coordinating everything and also sharing my slides. So thank you so much. It was I really feel honored to be here on this. Thank you so much to IPL.
Thank you, everyone. Thank you for this webinar.
Thank you. Good night.
Thank you so much.
Good night.
Good night, everybody.
Good night.
Good
Good
night.
night, everyone.